but and that's kind of just our high level as we were coming up with these strategies and these tactics, an idea. So that's to give you some sense, but until we actually like dive into actually doing that tactics or the actions, there's going to be more information that's going to be uncovered. And then we would come back to the board. If we are working on a specific tactic, we'd come back and say, oh, we found out that, this is more of the details of us really achieving this and being able to do something. Does that make sense?
Yes.
Okay.
I see the last 4 pages make it pretty clear. Yeah, thanks.
Okay. Awesome. So now we all get the opportunity to stand up and move.
We can scribe it, put out, or.
I don't know. Oh, look, there's 2 right here. Yeah.
Sorry.
Okay. We're doing our best. Okay.
I mean, you're.
Happy to bring it. It's back.
Together. This is from last year. I recognize that handwriting. Settle down. No, I haven't. Oh, yeah, thanks, man. A little like, well, pick me up.
What's up?
Okay, so this is which company?
Back
The speaker is. Friends, I'm gonna delete the chair maybe bring more. I wonder if we can join on our lap benefits. It's really other school districts that have or something like that, right? Like, but as far as I
Okay. I can. No, 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 no.
Dr. Lara and Misty, can you guys hear us now?
Yeah, we can. Yep. Thank you.
Good. Okay. So Dr. Lara and Misty, so we are the two values that we're going to be looking at in our breakout is going to be value 2, the active, and then also the value 3, culturally responsive. So let's start here first. All right, and then in the access to care, and I think what I'll do is just as we go through this, if you have comments or questions or concerns, we are going to kind of report out at the end, just so that helping involve the class. So really focusing on what that accessible, affordable, personalized care for everybody's unique needs. And so as we looked at the strategy, another one. So the first one, talking about Pfizer's doula network. Pfizer has proposed as part of the doula benefit. And there's some concern that by them kind of narrowing their network to just those two doula hubs, that there might be some areas of access or somebody's been having, another thing is if somebody is certified traditional health worker registry in the past and they wanted to use the same doula because that's a really important relationship for and now they can't, it would be considered out of network. Because we're doing narrow network approach. So one of our tactics here is really we just need to monitor that network because it's going to be new. And to see if there's member concerns. Do we see clarity on, like, just elaborate a little bit more on that first tactic, collaborate with carriers.
Dollars attached to that?
So,
Like,
I think the stats are pretty much like, yeah, so I think.
Because it's just asking Kaiser to give us some information, sharing engagement and utilization versus next year. So pretty low, no to low cost. It's just us doing the work, the health equity work group of kind of monitoring.
Yeah, helping.
My question is the smaller
Create guidance and direction.
savings involved with that?
How to help
Did we
members.
save money with Kaiser by going to a smaller doula network?
No.
Okay, so there's
I like that and
tracking thing they've done.
Yeah.
Okay.
It's just their approach and then.
because
There
there's
the other two carriers or the other one carrier with OEBB.
the classified employees
Only the
that
just traditional
really are
health.
not tech savvy. It's not how they learn, they do, like, they have a lot of trouble navigating those systems. And we have a few that have like reading disabilities
So
or
HMO,
really struggle to read
smaller.
at all. And so like,
And definitely
different
different
job maps and dashboards, there's all kinds of information, but it's, that's not how everybody.
So I guess on that one, any questions?
Information, and so, I do my boots on the ground stuff, go out to sites and help people in person with open enrollment and all that sort of stuff. They just want to meet to 1,087 employees. So if doctors. Yeah, well, and then like if doctors.
I know.
Yeah, I think we should,
Go back at 3:20.
and so they're really making.
It gives us like 10 minutes, so 25 minutes.
Maybe I have it,
10 minutes.
but they don't want to share their personal medical stuff, right? For me to give them the information.
Fix the form.
But say they have diabetes and they have MODA and could be eligible
Administratively, or did these come?
for one of those diabetes programs, right? Like,
if the doctor's offices knew
Yeah,
that,
that's a great question.
right,
So
they could connect them with those programs. And
Equity
so,
Work Group, which consists
There are a
of
lot.
staff, Mercer, and we have 2 board members from each
specific
board.
programs within those
Um,
groups
that we
we
listen
and
into.
another level of like access to that information. Where again, like, maybe I haven't reached out to or maybe they don't want to share that with me, but that's appropriate with their doctor to have those conversations and then they can find out.
Board members and saying, asking, are we on the right track here?
Yeah.
Any of these, like, do you have questions about any of these? Or there's any of these that you're like, oh, I don't really think we should be doing that? Or, oh, wait, you don't have this on. One thing I will say though is that these are new ones that we have a lot of tactics that we are working on.
It's probably, I mean, in your case, good leverage too.
That either like, we've done something about, or that is in process.
I also, I love
One of the things you won't see on here is behavioral,
an AI lens as well.
because we have.
AI can have some bias and have some.
Behavioral health network standards. And we've worked with the carriers now to get.
So, handle care.
So that's already, that's work that's already in flight. Which is why you won't see it on here. So these are kind of newer tactics.
Well, I think you can
Fine.
have
We're gonna do 2. We're
enough
gonna
education.
access to care and the culture responsive. I think it's, let's go through the access of care. And then-
Okay. And so the next one we have on here is
Most districts have,
they heard today.
Amazon has maybe some of these.
So we added that
You to know we're having a
as
workshop
an area
that
again.
meetings this month instead of that.
We don't honestly know yet exactly the how, and we don't have all the data behind, but we would go and say, okay, we now really
I don't know how people would get the information out,
network performance.
knowing really what their coverage is and going to someone
Go out and to see what is best.
asking what's available, and that's not something feasible. And, you know, in our area, there's not enough mental health counselors.
So there's 2 sides to this question. I don't know if this is saying
People don't,
to make sure that people are
you know.
able to call up and get an appointment as soon as they would like and as frequently as they would like? Or is it saying, dentists are
Like this month, I'm going to all
prescribing,
our sites to do drug
point of care, cleanings,
sessions, right? Like,
semi-annual cleanings, for example. Correct.
right, you know, so it's like,
Where-
again, that person might not want to be like, I have, Sally, I have diabetes.
No, it's
What is there
fair that you would ask that question.
Like, and
The context
there's
is
a lot of intimate conversations I do.
worried that there have not been enough appointments and having enough.
Understanding that.
So this is not able to get access to get in for cleaning.
Yeah.
This area I want to do more, and I'm always trying to do.
And guys,
Also, Kaiser has, there's some concerns with Kaiser.
If doctors have access to like all these programs, right, and it's kind of
Well, I know.
alerted in their system or somehow, right? Like, I
Issue myself,
possible ask, but right, like, then that's just another way to,
hygienists.
another way to get back.
Shortage of hygienists.
and that's throughout the entire, that's just everywhere, dental hygienists.
So I don't think that that has been resolved. But yeah, I think
Friday
that's,
night.
I would say from the other side
That's a good
too,
one, yeah.
because there's a lot of dentists that are doing 2 cleanings a year when it's, the data doesn't necessarily suggest people need it.
Not in any of these categories.
Plan allows it, so the dentist says, I want the money.
I'm looking for kind of more multivariate data that shows that,
And then the third one is monitoring network adequacy for language access for primary care, specialty care, and pharmacy. And this is really different to lots of different language access. I mean, they're supposed to have translation services available, that's required. But there is a little bit of a disconnect. And so to this one, like last year in the renewal letters, we asked how many times was a language service line used? And I think one of the
things like
carriers.
that. That's where, for me, I'm looking at this as equity, right?
That can't be
And
correct.
we all know there's bias in this.
And so
I'd like to
diving into this a
identify
little bit more,
Not other thing,
what do
just
they
say,
do for
hey,
language
we need
access?
to
Are they doing
policy
training
change.
on
the technology. I've been in a primary care office working, and oftentimes the staff doesn't know how to use the language line access technology.
We have
So
policies.
this would really be just diving more into that. And making sure that that's accessible. People who need another language for their care would be able to get it.
There is a bit of that. Yeah.
The fourth one on here is monitoring developing targets for primary care access. So very similar to the dental preventive care and the one that we're doing for behavioral health. Just focused specifically.
I was thinking on that. Trying to understand that.
Some place as well. So it also could include like how.
I think a lot of time when you don't have any money,
They picked.
really, I mean, what,
So can you give me an example of what a target might look like?
So, yes, so what we've done, and I think, particularly with primary care, they're
effectively by PR and like education that isn't really
standards
evident.
that are in place. We've actually in commercial market of what we know is safe. And so taking in all of that information.
You know, I'm looking at like the Know Your Care.
With at the time, it was the innovation work group that had that discussion, looking at all these different
Seems
standards.
like a veneer.
And so we go through this process. We did also talk to the carriers and negotiated, like,
And if we're not like measuring it,
what these are non-negotiables, what can we push you on? And then came up with that standard. So we develop it in the process as we work on the topic.
The other question I have is, for this particular one, does primary care include urgent care, or is it just senior primary?
In the lower end of the spectrum.
I
But
think
they
this one would
have
just
to
be
get kids with them
primary
to
care.
trans.
What we saw like.
That's just wrong. That can't happen. No,
Processing urgent care timeframe with a provider.
but it still can't happen. Right. And
If
that's
I
an
have an
equity.
urgent situation.
It cannot translate.
Can I, so that might be, I'm not as familiar yet with the.
Regardless of the language or whatever.
That's in there as far, then that would be something we could.
I think that would apply to Kaiser as well, because, you know, urgent's a little bit more difficult with Kaiser,
Okay.
because you have hospitals.
The office is supposed to provide that.
And-
We chamber one and they're not following it,
Not-
right,
Exactly.
right. So where's the teeth in that?
And so actually, I'll go back to, so all those four we just talked about.
I'm gonna say for removing barriers for
You know, in our high level kind of looking at this, that those
people
are.
who are not English speakers as a first language have a trust issue, right? That needs to
And
happen.
relatively low grades, no to low cost with all of those.
Yeah, but
The
anyhow,
last two on here, you can see that those change a little bit. So improving access to.
I have very pins, but like, these are my bugs.
Today. There is a gap there of the current benefits for certain benefits. And so, you know,
for the.
we want to keep this on.
The providers knew what was out there, right?
But it does have a much.
Then the people that, again, have reading disabilities.
Wasn't it like additional, was there 1 or 2% increase of premiums to get?
Now have a different access to the same benefits that everybody else gets, right? And aren't penalized because that's not how they receive.
And then the last one on here is an idea, this has come up before, but on-site clinics to reach areas with access consideration. And so we've talked about, I think the last meeting, or maybe one of the carrier presentations, they talked about like mobile mammography vans, vaccination clinics, and hospitals. Again, something that we can always reach out to the carriers and ask about what are they doing. There are other clients that are doing this. We're estimating though that that is going to be a mid to long-term goal to put into place and to take action.
I mean, maybe more plain language, but again.
The dental have a toothbrush that went around, tooth taxing.
That's what I was thinking.
So it'd be something along those lines.
Exactly, yeah. And again, you know, I think part of it too is like tracking it, knowing exactly what
And so
they're
that's
doing.
not all, you know, it's just the, again, that's
Somewhat
like
captured again with Health Act
one, and also,
But it is good to know, you know, if we can put some sort of like, oh, we, you know, how much information, you know, we reach previously, and now that we've done more maybe member communication or we've worked with the carriers on the schedule,
what
A
is?
few years ago,
So is the tooth tax still there or did they discontinue that?
equity assessment tool.
So it'd be good to know why if we're going to pursue this, right? Because there was a model and
Well, DSP has the vision thing too.
On the tooth tax, OEA used to contribute to it out of the wellness trust, and the previous board decided to cut it.
the wellness board.
But, we made some changes.
Yeah. So maybe that is a partnership with the wellness on these mobile pieces too. It's a catch, nothing to do, so maybe.
Yeah. And that's where vaccination clinics came up too, is that I think there are some school-based clinics right now that have vaccination clinics in them. And so, they're in partnership, what we could do there, just because we know that we lower vaccination rates in our population. So that was another area for possible partnership, kind of going on site versus expecting.
And Voda used to let us arrange for Safeway to come to our school's office and do a mass, vaccination clinic. Or staff would sign up and we always had hundreds.
Okay. Good to know.
Yeah, when I was in teacher in Medford, they did this, or I don't think it was Safeway, but we had the same situation.
Yeah, there was a couple of choices, but there's a Safeway right up the road.
For the flu vaccine, right?
I'm sorry?
For the flu vaccine.
Yeah.
So I guess overall alignment, did he make sense?
I'm familiar with these.
Personally, from an instinct place, I really wanna, ask, because the target is Medford access. Care that meets their unique personal needs, and I know it is affordable care. Almost ask members on a scale of 1 to 5, do you have access to
And in
care?
reality, half the time it's more than that.
And then, you mark that a 5 out of 5. What would a 5 out of 5 look like for you? I want to know I don't know to what degree these would surface for members. I'm making up a way to hear their voice, but I don't know whether or not OM members would say that these are their priorities. For sure.
Yeah.
I don't know if they do either.
My guess is that they're not thinking at this level. They're thinking higher level.
But I think if you ask a question around specifically access, like dental cleanings, that kind of stuff, I think you would get feedback.
I can go get healthcare when I need it. Yes or no? Scale of 1 to 5. I think that they could answer that. How to improve and make it 5 out of 5 would be, that would be, respondent. Some might say, gosh, my doula is no longer part of my network and I'm really upset about that. Others might say, you know what I'm saying?
Yeah, we certainly don't have membership every other year.
So I
You
think
get billed for that kind of
So I
staff
guess
satisfaction
talk
survey.
about like expectations and being able to
There's an opportunity to think about that.
that does kind of come up in that culture responsive care one we do. Because I think that is, one component that is getting that member.
The only time this year.
And again, that's one area where we really rely on.
There's an
bring that
expectation
forward.
gap.
If you're hearing things or something like that, but then also.
Honestly, sometimes save up everything they want to talk about for their annual benefits. And then they get there and they're told, no, I have time, make another appointment, and there's this, so then that's a dissatisfaction.
The next page, Chris.
Okay. So the next one is culturally aligned care. And so this is really, again, members interactions with healthcare system, inclusive of their backgrounds.
When I try to make an appointment for my annual, there's this pop-up.
And so
Not to discuss any health condition, any current symptoms you have,
You know what, listen to my heart. So those preventive care are a huge plus in terms of having those, barrier-free first coverage, but I also think that like.
And so we felt like it was
We
an
don't
important
wanna step
tactic for us to monitor
Being more than they
them on a regular basis.
There's,
Keep that going. Are you doing
I
this?
can't tell you how many conversations.
And,
I've
again,
had
it
where
really
it's like, it's not that I don't want it, but there's full care
and that, they're, as an organization, because they do that behind the scenes, that some of their organizational structures, what they're doing
That's a piece of it.
behind the scenes that we don't necessarily see.
Yes.
Is it just at the carrier level or are they also filtering down to?
We got 30 minutes to get there.
What- I don't know exactly, accreditation is.
We do have all the standards to look at it. We're too much focused on the organization.
Or if you think about preventive care.
Some components of it is how they're ensuring their provider, place when that's needed.
Whatever else is covered, that's like discrete.
So that does.
Where when you go to your mammogram,
Especially when you're
got like a weird pain you were having in your ankle or something.
Yeah.
Yeah. It is, but.
A little bit on the provider.
One of your. If you're a woman, you get.
Having, requiring our carriers and their vendor partners to have,
Suddenly really loving my doctor because she's like, okay, what do you need? I got it all right in 15 minutes.
right now, just licensed providers in Oregon have to take part of the license. It's required that they have, the training, I think, every 3 years, which is their regulation as they get, licensed. You have to- But really for, member facing in by so it feels like in place. And so that means that
Feels like that works.
when members and PEP members are, have had this training and.
Sorry, guys.
Vendors like
In the mail,
the-
my husband goes to the doctor and says, I have, da, 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 and I need,
Already
da, 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 and the guy writes out a prescription. I go in and say, can you do something? I have the shoulder pain, da, 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 da. I go home with ice pack.
Talking about that.
I go to my husband every time I said, "Why? I'm just gonna go in with you. And I'm just.
Between that phone, I've had, some sort of culturally responsive training so they know.
Is there any, idea outside of our purview, but like, I'm just thinking about how.
Go back to that, to the member's perspective, the consumer's perspective.
Thought about, like, why don't we just, like,
That would be important to listen for, to seek out.
the doctors come to the place where the people are.
The carrier and the provider, because I think. Responding.
I mean.
Their ecosystem, if I'm talking about the dental hygienist. She really cared about me, you know what I'm saying? That's gonna be a different response than maybe the phone call that I make to the carrier.
Yes, that makes sense. I'm not just sure about that.
Providing a report out to the clinic.
I think absent the member's response,
So at Menographics, before we got bought,
measures that are in
once a year in the CAF, you would go station to station. And if you completed all the stations, you got
ever be in a position to answer our.
and one of it was a survey. And so you would get weighed, you would get your cholesterol.
Successfully educating your children.
To all six.
Ask you as a parent that question. Not, you know what I'm saying? Do you like your meal? I'm gonna ask the person at the table, I'm not gonna ask the chef. So, that's my own take.
I'm wondering, I think like we have separate questions, like.
Everybody got a police out there.
You're right, I think some of the questions.
You gotta wait 3 years to do that in school district now.
Yeah, we were just.
Have that option.
Clinic.
She was my question.
Request when, we have a provider that'll go on site.
Versus, I feel like my provider listens to me.
It's just a function of time. So just look at optometry.
I just haven't seen the survey. I didn't know that there was a survey out there, so I think that's.
The burns, right? You just have to have a group that's willing to go out there.
I'm not thinking these questions are in our.
So also the penalty price for doing what we used to do at Menographics is your data had to be submitted anonymously.
Then the next one is monitoring carrier and vendor provider networks.
None of us cared. We were like, yeah, we don't care.
This is one we are already doing with behavioral health.
Yeah,
We just
it's a
received
not-
reporting from the carriers.
I like little wheels going because like we have a boarding wellness clinic.
It's a tricky one.
You know, clinics and stuff like that, but I bet we could get our
Are we talking about the diversity of the providers?
certified sites of Harvard to all of
Yeah,
them,
because
but
there's
like
a
at least in our
and
region.
is that a lot of research shows that,
You know,
if I go and see a provider
basic.
like me, has the same lived experience, might have some
New venture.
So this is one that we always just like to see improvement. Are we seeing
You know, it could
improvement?
probably be leveraged from multiple sources, the same thing.
But this is relying on carriers
It's
to
this actual model where you just observe
but it's
it
something for ongoing monitoring and even
at a population conduct.
one is the behavioral health network diversity. Link with that and that may inform
I realize
other
there's
provider
a
groups.
lot of other considerations, but it could be.
How will you know when you got there?
Into that.
It's good to know.
So that's a great question too. You know, I think one first thing is you try to make sure that you're
Calling out.
bringing us back.
No, you're right.
So you kind of look at that. Now, obviously, there's gonna be some access issues, you know, if there's a certain provider that's only in the Portland area and there's somebody in a rural area, then that also is part of the, looking at.
So we're leaning towards.
Oftentimes you can find providers, that meet your needs, sometimes more in a virtual. The next one is expanding current minimum language for all member-facing communications with print and digital. I think Enrique, oh, did I?
Prioritize
yes.
collaboration.
Thank you. So, next one, sorry, prioritizing collaboration between carriers and health equity-based organizations statewide. So this is really just that they have really encouraging the collaboration. So oftentimes carriers are referring to maybe such a community-based organization
And on the OEBB.
that is already in the community, they're doing the work.
Not 100%, but the.
So instead of that carrier trying to, in their own silo, get a resource for that member,
You could just cash.
partnerships with community-based organizations within that community, oftentimes that member's needs get met at a higher level. And having those partnerships helps increase knowledge, understanding of different communities and what their needs are, again, versus a carrier working like in a silo.
So why is this one possibly a medium cost as opposed to?
It felt that it's harder for us
Number 5 we've
to,
already done. That number 5 is actually a check. That,
to
that
get the carriers to do it, so there might be.
That was explored.
Got it.
Yeah.
Yeah.
Okay, and then the minimum language standards, expanding current, so this was something, maybe you brought this up before, as we talked about, you know, right now, we're working towards that English and specific payment for traditional minimum language standards. And I think that's coming up next year, 2026.
Yep.
We just did.
And from there,
It was only.
do we need, you know, what?
Those are the only ones that actually
Boston and Oregon, and so do we need to?
We'll actually have data.
What those next languages, because you'll be able to continue to always not saying that, okay, we got English and Spanish, we're done.
That makes sense.
The next one is engaging members to determine if their experience with access to care and benefits materials.
Sorry, do we segregate it all when a nurse practitioner
It gets to the
care
survey,
versus a doctor?
Tony, that you're talking about, you know, having
Same,
questions.
same everything, right?
In terms of the reimbursement?
Or just our plans?
And I think again,
Anything that prevents a nurse practitioner from being effective.
I mean, certainly they, you know, any provider up to their scope of
one
practice.
of the things when we looked at this,
Their life insurance and, you know, as long as you're contracted with
when we saw earlier budget, was
potential
So we don't pay
Way a doctor for the
for a nurse practitioner given it.
be done.
And I.
Maybe a survey.
That's wrong.
Yeah. There's no like traditional health worker code.
Well, for medical.
Well, nurse practitioners.
Billing code.
Yeah. It's done in Medicaid,
Sometimes I feel under an empty.
Don't know exactly.
There's,
They have to be supervised.
That it might
yeah,
be.
well, there's practitioners
Who adopted the national class standards, which are the cultural standards.
know, it's interesting.
It's great to see.
Yeah.
As a provider, if you are bilingual, speak different languages, take
So maybe that's what I.
certifications.
No, she
Right
was-
now, they actually.
I mean, it's an interesting question.
Additional amount if you're a class certified provider, and let's say I'm providing behavioral
Like across the board, I'm not sure, like.
PCP's office.
This is one thing we're doing in private industry.
So that's just one.
Yeah.
No.
Having that additional service and people's needs.
That's on the provider level. That's at the doctor level, not at the carrier level.
Exactly.
Yeah.
That's just what we have.
They are rewarded financially
Yeah.
for doing it. Is that on claims basis? Is it a bonus basis? I mean, how that happens?
I think it's an additional CPT code that they're adding with their coverage standards.
Every single service provided.
Well,
Yeah, I don't know how, those rates.
we can that out.
Sure.
Could possibly verify.
I'm just curious.
Yeah.
Not important. Just curious.
It's something we would uncover as we.
They're working under some doctor.
But we didn't answer your question.
Really good. You guys have been doing some work.
Love it. We did. I mean, this has been really a collective brainstorm.
Still out there.
And then again, the input from our board members.
Done into bite-sized pieces. That's like,
Say we really want this.
So is there anything else?
I told like, Kaiser and Moda over this last year, being willing to like come in person.
We love to hear
Which, you know, I didn't realize they would do things like that. So that was really cool. And anything kind of, again, took down a barrier and offered another way to access.
I do have a question on the.
Especially Canopy did that without.
You said every 3 years.
I was just gonna.
from licensed providers. It's part of the,
In our previous meeting,
the
says
legislative.
we never.
for licensing.
I think they're easy to use and stuff. I just like, we haven't had them come down to do anything in person because, you know, they just pay for travel and for the time there.
One of the programs that
I understand, and also it's hard to, yeah.
The question I have is something that.
In a $1 million budget, it's okay.
Doctor, my provider, but yeah, month and a half. That I
Clear process for.
can't really measure that because if you have access to healthcare, I find out. Because the provider I need to see to get a cream or whatever, it's a month out, now I have to go to the provider.
To appointment.
Yeah.
Great for that.
But, broken down by.
How's that being measured?
They're working on that.
So like what we're doing right now with the
And they
Behavioral
are-
Health Network standards is all of the carriers did a secret shopper survey. So they basically pose as a member, call in, and they have a certain subset of their provider network that they had to outreach to. And then they would basically just try to make an appointment. And so we found that out of the 2 carriers with OEB, there are definitely some areas that they don't have the access that these standards, kind of what our target goals are. And so that's where we're, so first we established a base secret shopper.
So.
And then now we're in the process of what are our
Or if
premium.
it's not.
So secret shopper is one way to measure it. And my understanding is Medicaid is requiring secret shoppers as well.
Yeah.
Saying that folks in here oftentimes align with what Medicaid is requiring. Because a lot of times our carriers are doing it anyways. So I think that would be one. I think it's great to hear the members' perspective.
Where you live.
But also, kind of.
But the member lives in.
Sheep order up at the top of the hill, you're not gonna come down until it's time.
That's when they could have the best absolute experience. Here and the doctors, it was perfect. And yesterday I couldn't get in when I wanted to, so it was all crappy. It's human nature.
Warm up to
Human
it.
nature. See it all the time.
All right, and I think are we gonna ask today just to make sure that for the board to adopt a strategy?
I know in our school district.
It was mentioned, but we can always bring feedback to the committee and
Teachers can go to have privacy, to have a
the
telehealth.
feedback that was noted.
So they reserve it for that time.
Yes, we'll combine all of our feedback.
Do you think that after COVID, people would be more used to telehealth?
I think if we
Still
the same, okay.
Like, we're fine.
Which is more efficient.
You guys are. I love it.
It's over. I get things.
Guess we're out of time.
We improve all the aspects that make me here.
Yeah.
And the line.
I know that.
I don't know that we necessarily. Sheriff.
We're,
Oh, okay. Oh, that's fine.
That's a good.
I was thinking Greg, but now I got it at home. I can bring the file there and let it go.
Right.
Oh.
Another.
I would have demanded we do.
Reveal and then.
I write, everybody would be much more.
You know, people. Try to piddle. I know.
Ten more.
I know, look. I saw that on- Yeah. That and the payment.
Do a quick little summary recap.
Upper body.
Good for that, Maggie?
Good.
Let me look at this.
Okay.
Yeah, they on CNN did it.
Oh, yeah.
The new payment. Well, people are distrusting, just when you say payment, it's like, so we need to get faster.
Opioid crisis thing.
Yeah.
Yeah, yeah.
That.
Now we can.
I'm not. Sorry, I gotta go get my grandson.
Oh.
They're having him a snack. I regret giving him this kind of snack.
Yeah.
Like, come here.
Might be a little easier.
I was just gonna say, have you heard of the other coaching, potential coaching?
Well, I think we'll